Hi, my name is Amanda Comstock, and I am a DNP AG ACNP candidate for graduation December 2025. I'm here today to present to you my DNP research and scholarly project entitled Post-Intensive Care Syndrome, Early Identification and Providing Resources at Discharge. The following individuals comprised the committee for my DNP research. My chair was Dr. Maria Snell. My NURS 705 faculty and second reader is Dr. Rita Wunderlich, and my chosen community member is Kyle Krager, ICU Director. Post-intensive care syndrome, or PICS, is a combination of cognitive, psychological, and physical impairments that can affect ICU survivors for years after they are discharged from the hospital. Anxiety, depression, and post-traumatic stress disorder are psychiatric complications that this patient population is especially vulnerable to. The purpose of this scholarly project was to develop a high-quality, evidence-based clinical practice guideline that identifies ICU patients who are at high risk for developing the mental health consequences of post-intensive care syndrome. A comprehensive review of the literature examined all evidence supporting the use of an early identification tool for post-intensive care syndrome and the need for providing mental health resources at discharge. There were three recurring themes that were identified throughout this synthesis: risk factors for post-intensive care syndrome, psychological morbidity associated with ICU survival, and defining healthcare needs for ICU survivors. Some of the strengths I identified: all of the studies reviewed were comprised of randomized control trials, cohort studies, and cross-sectional observational studies, which means this literature is comprised of high-quality evidence to support the research question of inquiry. The sampling method for patients at high risk for developing PICS is specific to the end cause. Therefore, it does not follow traditionally reliable sample types. One study was extremely specific in identifying their population to investigate. These patients must have been on the ICU for 72 hours or more, as well as have utilized mechanical ventilatory support for 24 hours or more. Now, while this drastically narrows down the total number of patients on an ICU, it is this population who is the most susceptible to developing the physical, mental, emotional, and cognitive detriments secondary to their experiences. Some of the weaknesses identified: using a sampling method such as simple random sampling means that all subjects are selected for the sample group, which provides a greater insight to the results of an entire population. With regards to the ICU setting, not all patients are at high risk for developing PICS. Therefore, the entirety of the group would not be beneficial in understanding the specific requirements for this subset of ICU patients. Some of the studies also simply focused on one hospital setting for all of their research. Small sample sizes can limit the amount of data gathered and even create bias amongst it. The data will yield more unbiased and generalized ideas about a population if it is expanded to multiple ICU settings at several institutions, and if the researchers are able to expand to more geographical locations, the research will tend to show a true representation of the question at hand. The theory that supports the development of a clinical practice guideline is Lewin's change management theory. The premise of Kurt Lewin's theory is to address the already existing mindsets about what it is to be changed in three different steps: unfreezing, changing, and refreezing. The unfreezing portion of the theory involves demonstrating a need and educating on the importance of the change, and remaining open to concerns and questions. The changing portion of the theory involves understanding uncertainty and continued communication throughout the entire process. And lastly, the refreezing portion of the theory involves identifying barriers to the change, establishing reward systems, and continuing to show support and open communication. For the purposes of creating a clinical practice guideline to address the question of inquiry, addressing Lewin's three steps will be a crucial component if the organization chooses to implement it into practice. When convincing the stakeholders on the importance of using the CPG, They needed to understand the need for identifying patients who are at high risk for developing PICS and the consequential mental health struggles that accompany it. They also needed to agree that there is a need for providing these patients with mental health resources at discharge, the unfreezing portion. Overall, there was some uncertainty amongst the stakeholders regarding understanding the tool to be used for the identification purposes, choosing the mental health resources that will be included at discharge, and the workflow process needing to be executed properly, the changing portion. Lastly, the stakeholders identified barriers to the actual implementation of the guideline, as well as encouraged the hospitalist team to provide these resources to this specific patient population as part of the discharge process, thus showing their ultimate support for the clinical practice guideline. The question of inquiry for this research was, does the development of a clinical practice guideline for the early identification of ICU patients at high risk for the development of post-intensive care syndrome using the Agree-To tool facilitate agreement amongst the stakeholders for future implementation of the guideline at the hospital? This was a non-intervention project that was focused on the development of a CPG. There were no human subjects that were necessary throughout the duration of the project. The reviewers were identified as stakeholders and asked to use the Agreed-To tool to evaluate the CPG prior to the official presentation for consideration. Their feedback was recorded in field notes after verbal conversations with each selected reviewer. This project developed a CPG that sought evaluation from the reviewers using the Appraisal of Guidelines for Research and Evaluation 2 instrument, or Agree-To. This clinical practice guideline was developed for use in an ICU setting located in Iowa. There are currently no interventions in place that identify mental health needs at discharge and incorporate them into discharge planning. Again, there were no human participants that were required for the outcome of this project. Once the CPG was fully developed, I identified reviewers with expertise in the area as well as direct involvement of the practice should it get implemented. Their feedback and involvement was completely voluntary. The reviewers needed to have been 18 years of age or older, currently working in the ICU setting at this hospital, or a provider in this specific hospital who has the privileges to prescribe mental health services at discharge as needed. Descriptive statistics helps to provide a concise summary of collected data that outlines trends and an overall conclusion to the dataset. This type of statistics is beneficial in the development of a CPG as it can create visual aids. Those help reviewers to see the overall recommendations outlined very clearly in formats like graphs, tables, pie charts, bar charts, etc. For the development of this clinical practice guideline, I developed a PICS high-risk assessment tool that was to be utilized by every ICU nurse on all patients. The criteria for this tool included a diagnosis of sepsis, the patient suffering a cardiac arrest during this specific admission, a pre-existing diagnosed psychological disorder like anxiety, depression, or PTSD, mechanical ventilatory support for 4 or more days, and a positive CAM ICU score at any point in the admission. If the patient screened yes to any of these criteria, the patient would be identified as high risk for developing PICS, and the providers would be notified. Within the group of selected stakeholders, 100% of them were healthcare workers with ICU-specific experience. Among the group, 50% of those reviewers were registered nurses on the intensive care unit, 25% of the reviewers were in a management role, and another 25% held the position of Director of Critical Care and Pulmonary Services. All of the reviewers held advanced degrees, with 75% of them holding a Master of Science in Nursing degree and 25% holding a Doctor of Medicine degree. All of these individuals were practicing in their professional roles at the time of the review. The agreed-to instrument is structured so that data is collected on 23 individual items, which are then subsequently grouped into 6 total domains. Those domains are scope and purpose, clarity of presentation, stakeholder involvement, applicability, rigor of development, and editorial independence. Those 23 items are then scored on a 7-point scale. A score of 1 indicates that the evaluator strongly disagrees, and a score of 7 indicates that the evaluator strongly agrees. Those scores were then added together within the 6 individual domains to calculate the total score for each domain. The following graph shows total points possible versus total points awarded by the stakeholders per each individual agreed-to domain. An overall quality score was calculated for each of the 6 domains. The domains are independent entities and therefore should not be calculated into one overall composed score. I took the minimum possible score and the maximum possible score for each domain and calculated it using the instructions directly from the agreed-to instrument. To calculate the minimum possible score, I took 1 times the number of items within each domain, multiplied that by 4, the number of appraisers. To calculate the maximum possible score, I took 7 times the number within each domain, multiplied again by 4, the number of appraisers. Once those calculations were completed, I used the equation for a scaled domain score, which uses the values from the minimum and maximum calculations. That equation takes the minimum possible score subtracted from the obtained score, divide that by the minimum possible score subtracted from the maximum possible score. That value is then multiplied by 100%. Calculating these scores via these specific equations allows for an evaluation of both the strengths and the areas of opportunity within the researcher's developed clinical practice guideline. Using the agreed-to tool does allow for autonomy in the interpretation of the data, meaning there are no set standardized benchmarks within each domain that must be met in order for the CPG to be implemented into practice. I opted to set the benchmark at 90% across the board to establish equal importance among every domain evaluated. That benchmark was achieved, therefore it was deemed sufficient enough for implementation. The following chart describes the domain quality scores. Each 6 domain, its minimum possible score, its maximum possible score, the domain total, and then the calculated scaled domain score. The agreed-to instrument provided the instructions and guided the data analysis methods. There were some limitations identified in the development of the CPG. For example, this guideline was developed by one single person as a part of a scholarly project in a Doctor of Nursing practice program. It could have been more thoroughly developed had a multidisciplinary team been enlisted during the initial phases of the project evolution. If this was an implementation-focused project, that may have been imperative to receive buy-in from all the necessary stakeholders, including staff ICU RNs, intensivists, hospitalists, social workers, and outpatient mental health providers in the community. The second limitation of this project is that the PICS risk assessment tool is used by the ICU RNs, and then that recorded data is forwarded to the provider in a request for a referral at discharge. At no point is the patient included in the plan of care to assess their current mental health needs, perspectives, or feelings surrounding their ICU survival. Many patients may not continue to follow up with mental health providers after they leave the hospital due to apprehension, compliance, or simply feeling that it's not warranted. Patients will only participate in care or remain compliant with their treatment if they feel it is warranted, if they trust their providers, and if they have the financial means to do so. If the patient does not believe in mental health practices for personal, cultural, or spiritual reasons, then they are not ever going to follow up with a mental health provider at discharge, regardless if they screened high risk or not. The third limitation of this project is the absence of written comments on the appraisal to itself. The 2 guidelines at the bottom of the tool discuss recommendations for implementation, and allow for comments to be incorporated. Unfortunately, only 50% of the appraisers completed this section, despite the researcher explaining the tool to them. While this data was not incorporated into the final calculations, it's very helpful in determining things that need altered or improved prior to the actual implementation of the guideline. Using the Agree-To tool does allow for autonomy in the interpretation of the data, meaning, again, there are no standardized benchmarks within each domain that must be met in order for this guideline to be implemented into practice. I opted to set the benchmark at 90% to establish equal importance amongst every domain evaluated, which was achieved. This guideline supports patients in the critically ill populations in ways that aren't currently being addressed. These ICU survivors have potentially faced one of the most traumatic events of their lives. It is imperative that we are addressing these mental health needs and providing the necessary resources to these patients after discharge in an effort to treat the patient in the most thorough and holistic way possible. This project's results support this idea and place importance on the prioritization of identifying patients who are at high risk for developing post-intensive care syndrome. Post-intensive care syndrome is a life-changing complication that patients may experience after surviving a critical illness. This CPG was developed to address an area of opportunity for these patients that focuses solely on their mental health needs. Addressing a patient's potential for the development of anxiety, depression, or PTSD secondary to their ICU experience can promote overall healing and medical adherence to directed therapies. It is the responsibility of healthcare providers to advocate for patients, encourage them, and educate them on how to promote enhanced healthcare experiences and improve applied treatment modalities. Patients suffering from PICS need a voice, and this clinical practice guideline is just one more way that we can give them a fighting chance. I identified implications for practice in two specific areas: implications for nursing practice and implications for future research. PICS is an adverse outcome recognized nationally in this specific patient population, yet there is nothing standardized with regard to screening for their mental health risks. This guideline was created with specific recommendations for use in the critical care setting. This guideline has the potential to improve long-term patient outcomes as opposed to only focusing on their comorbidities in the inpatient setting. Critically ill patients don't always succumb to their illness, and when they don't, they can be left with severely debilitating mental health disorders. If this guideline is implemented, these patients have the opportunity to proactively address the newly developed or exacerbated chronic mental illnesses. Understanding the effects that life-saving measures have on a patient's mental health is imperative to increasing compliance and compassion towards implementing PICS prevention strategies. With regard to future research, PICS is something that every single ICU patient is at risk for developing. There are physical, emotional, and psychological manifestations of this complication that are addressed every day in critical care settings. Many of these current policies address the physical manifestations and utilize early interventions to combat those difficulties. The emotional and psychological outcomes are seldom addressed, and this project has identified a need and an opportunity for improvement in this area. Additional policies need to be incorporated into all ICU settings that identify patients who are at high risk for developing these mental health concerns, and we should work diligently to bridge the gap in attaining valuable resources. Evidence-based clinical practice guidelines ensure that we as a medical community are providing care to patients at the highest level. This project aimed to yield better mental health outcomes for patients who have survived critical illnesses in an ICU setting, and at the very least provide guidance and awareness to ICU staff regarding post-intensive care syndrome and the devastating consequences it can have on this patient population. The overall recommendations for this CPG are encompassed in the PICS risk assessment tool that I developed. This screening tool is to be used by every ICU nurse on every ICU patient. This tool addresses patients who have a sepsis diagnosis, who suffered a cardiac arrest during this admission, who have a pre-existing diagnosed psychological disorder like anxiety, depression, or PTSD, utilized mechanical ventilatory support for 4 or more days, or had a positive confusion assessment method score. If yes was answered to any of those key items, the ICU nurse is to report a positive PICS risk finding to the attending provider. The attending will then consult mental health services at discharge for the patient to follow up with on an outpatient basis. Through data collection using the agreed-to instrument and the subsequent evaluation of that collected data, it was determined that this CPG is a high-quality guideline and can be implemented for use. Thank you again so much for listening to my final DNP presentation. Have a wonderful day.